Hello, everyone. I'm glad that it was made possible to connect with you virtually for the Symposium 2021. Hopefully for the next symposium, we can be there. I've been to Uganda twice already, and some of you might remember me from the last symposium, some might not. I'm Dr. Parvaneh Bahrami. I'm a periodontist at the Prosthodontic Associates, and also I teach at the Faculty of Dentistry, University of Toronto. Today, as the title slide shows, I'm going to be talking about the etiology of periodontal diseases and how it links to the systemic diseases. Let's just start with talking about the high prevalence of the periodontitis. It's the most common oral condition of human population, and it's one of the two biggest threats to the oral health, the other one being dental caries. One of the surveys that support this high prevalence is the National Health and Nutritional Examination Survey done in 2009-2010 in US. It was a huge survey. It involved children and adults. And in terms of periodontal evaluation, it was a unique survey because it included a complete mouth periodontal evaluation. The previous ones, they only had conducted a partial mouth periodontal evaluation. And we know that the periodontal disease is not evenly distributed. So in a partial mouth evaluation, we can miss out some of the disease indicators. So this is basically, this makes it the most comprehensive survey of periodontal health that ever was conducted in US. It has very much valuable information, and the CDC, based on this survey, announced that 1 out of every 2 American adults has a form of periodontitis. At that time, we're talking about something around 65 million of US adult population, which is huge. There were other results of this survey that were also interesting. For example, men are more likely than women to have periodontal disease. Almost 65% of the smokers have periodontal disease, and some other information about the risk factors and risk indicators that we're going to talk about later. But it's a very unique survey for periodontal evaluation for the reason I explained. So periodontitis is the main cause of tooth loss. It's a major public health problem because of such a high prevalence, and also causes significant dental care costs, possible negative impact on the general health, and also a source of social inequality. Why? Because everyone likes to have a beautiful smile and likes to see a beautiful smile. Even during the pandemic, people found a way to show their smile through the mask. So let's talk about the etiology of the periodontal diseases. I start from the hypothesis that was introduced in this regard. First one was in 1975, Loesch introduced the non-specific plaque hypothesis. He said, we know that the bacteria in dental plaque causes inflammation. This was supported by a very classic study by Lowe, which was the experimental gingivitis, showing that if we cease our oral hygiene, we're going to have gingivitis after a certain amount of time. And if we resume our oral hygiene, that's going to be resolved. But the question is, when that gingivitis turns to a periodontitis, how did that happen? What Loesch introduced with this hypothesis said, if this bacterial accumulation reaches a threshold, that's when the period tissue destruction starts. In 1984, Socrates came in with the specific plaque hypothesis. He said, okay, the non-specific hypothesis is partly true. If we don't brush, we get inflammation, we get gingivitis, but the loss of connective tissue and the loss of bone that are hallmarks of the periodontal disease, they are associated with much smaller group of bacteria. And he found the dental plaques in the healthy sites are distinct from the one isolated from the disease sites. His hypothesis was supported by numerous studies done on the composition of the subgingival plaque versus supragingival, healthy sites versus disease site, and in different forms of periodontal diseases. As a result of these studies, Socrates in 1998 introduced this pyramid model from the coaggregation model of the microbial complexes in a dental plaque. He divided the bacteria in a dental plaque to 6 color-coded complexes based on the timing that they come and colonize in the dental plaque, and also based on causing a periodontal disease. So if you see at the base of the pyramid, you can see blue, purple, green, and yellow complexes. These are the early colonizers. It means after your cleaning, as soon as you walk out of the room, some of these bacteria already are sitting on the root surfaces of your teeth. So they are the one that come first. They start building a house, preparing the environment. Then the orange complex comes. Orange complex acts as a bridge between the early colonizers and the late colonizers, which is the red complex, bacteria in the red complex. And those are the ones that they cause periodontal destruction. So think of it as when people want to move into a house. Think of it as building a house. When people want to come and reside in a house, there's a lot of preparation that needs to be done before they are able to live in that house. So think of these early colonizers at the base of the pyramid, the ones that they prepare the environment and they build the house for the red complex to come in. So what's the clinical importance of this fact? That explains the recommendations of periodontal maintenance every 3 months for most of our patients with periodontal diseases, because it almost takes 3 months for the other complexes, for the early colonizers, to prepare the environment for the red complex to colonize. So before the red complex gets comfortable and start destroying the periodontal tissue, we want to get in there and disturb the environment, destroy the house, that the early colonizers, now they have to start the house all over again and start from the base of the pyramid. That buys time for our patients, for the productions of this microbial bacterial plaque doesn't go to the circulation. So basically we buy time by these 3 months subgingival scaling and root planning. I want to talk about a concept here. Koch postulates is, they are the criteria that Robert Koch, German physician in 1890 introduced to see if there is a cause and effect relationship between a disease and a bacteria or any other microorganisms. Some of these criteria, it's a bunch of criteria. Some of them are like bacteria must be present in every case of the disease. We must be able to isolate it from the host with the disease, grown it in a pure culture. If we inoculate that culture into a healthy host, the disease should appear. So basically, Koch postulate has its own limitations. They found not all people infected by a bacteria may actually develop a disease. Some of them, they have subclinical symptoms rather than, it's a subclinical condition rather than showing the symptom of the disease. Sometimes a harmless bacteria can actually cause a disease under certain conditions, or if the host is immunocompromised. So basically, the periodontal disease did not completely fit into this model. And it was decided that while bacteria are necessary for the development of the perio disease, but is not sufficient for the clinical manifestation of it. And that's why the consensus came to no longer can periodontal disease be considered a simple bacterial infection. Yes, the non-specific hypothesis and a specific hypothesis are partially true, but in reality, it's not that simple. Rather, perio disease is a complex disease. It's multifactorial in nature, and that's why it was introduced as it's a complex interaction, a detailed interaction between the subgingival biofilm or the microbial challenge, the host immune system and its inflammatory response, and the risk factors. So everyone started realizing that for perio disease, we must actually focus on the evaluation of all factors responsible for the emergence of the disease. So we also realize the importance of focusing, restoring, and maintaining the patient's overall health. We can't just do our intraoral examination to decide on diagnosis, prognosis, formulate our treatment plan, and start treating without any consideration to the patient's overall health and even their lifestyle. It became more and more apparent that the host inflammatory response to the subgingival bacteria is responsible for the tissue destruction and the tissue damage, most likely progression of the disease. So we know the inflammatory response is actually a beneficial response and beneficial process in our body. It's the reaction to bacterial challenges. It happens routinely in our body, and that's how body fights the microbial challenge and eliminates them. It happens without our awareness. We only become aware of it when the response is prolonged and the body cannot and is not able to resolve that, cannot win that microbial challenge and eliminate it. So that's when the inflammation turns into chronic inflammation, which is a destructive process. So due to the action and the products of the inflammatory cells involved in the chronic production, then the tissue damage begins. Even in the healthy periodontium, when we chew or brush our teeth, we introduce bacteria that exist in the clavicular fluid to the circulation and to the bloodstream. What happens? Again, our immune system provides the inflammatory response, which is a protective response. But again, the problem arises when body cannot resolve this microbial challenge that has been introduced to. And that's why a new model for the pathobiology of periodontitis was presented, which also explained how periodontitis may relate to susceptibility for some certain systemic disease, such as cardiovascular diseases. This diagram explains what we talked about, the pathobiology of periodontitis in a simple way. And I'm going to even simplify it further. Periodontitis, as we see in the first one, microbial challenge, is just a small group of gram-negative bacteria that are present on the root surface as a biofilm. Now, they are producing lipopolysaccharides and virulence factors and other substances that now they have access to the gingival tissue. What happens? We talked about it. Microbial challenge, now host has an immunoinflammatory response to it and produces a bunch of substances that we can call all of them under pro-inflammatory cytokines. Let's call under the umbrella of pro-inflammatory cytokines and simplify it. So they induce production of the matrix metalloproteinase, MMPs, that they are responsible to destroy the connective tissue. They are responsible for production of, they also, that inflammatory cytokines, they produce prostaglandin, which is responsible for the bone loss. So that's when we see the clinical signs of the disease and the progression of it. At the top and the bottom of the diagram, you can see there's also environmental and acquired risk factor and genetic risk factors involved in this process, which I will talk about it later. Let's now that we are talking about the pathobiology, let's talk about the link between the periodontitis and some of the systemic diseases. We said that the host immunoinflammatory response produces pro-inflammatory cytokines. So these are now released as part of the response, our immune system response. These pro-inflammatory cytokines now may enter our bloodstream from the inflamed periodontal tissue. If it happens in an amount that is pathogenic, then we see the damage to the tissue. These pro-inflammatory cytokines were responsible for the damage to the connective tissue, for the damage to the bone. So now imagine they are in the circulation, they can damage the endothelial wall of the vessels. They can cause platelet aggregation and adhesion. And they can also induce macrophage infiltration and proliferation. All of this results in formation of thrombus or atheroma in the blood vessels and thickening the wall of the blood vessels. So what happens? If this thickening happens in, for example, coronary arteries, then it means that the patient, it can lead to angina or myocardial infarction or heart attack. Or maybe a thromboembolic event happens, which means this thrombus blood clot gets loose, goes to the circulation, and plugs a vessel in an organ. Like if it plugs a vessel in a lung, it causes pulmonary embolism. If it plugs a vessel in brain, it causes strokes. It can go plug a vessel in kidney, leg, GI tract, name it. So how literature supports this link? Literature supports a modest association between the periodontitis and atherosclerosis, cardiovascular disease, stroke, and so on. Some studies do not even show this association. And they say, let's blame it on, it can be blamed on the absence of the standard definition and measure for periodontitis. The other one is the confounding factors are common to both conditions and complicates to interpret the result. What does it mean? If you had noticed, most of the risk factors in these conditions are common, like smoking, male gender, race and ethnicity, stress and aging. And that's why there is a discrepancy in the literature. Now let's go back to talking about the risk factors. So risk factors are the characteristics that are associated with the disease. They are identified in longitudinal studies. The most important ones are in terms of risk factors for periodontal disease is diabetes. We know that if there is a perio disease, there's an inflammation, and that inflammation causes to increase their insulin resistance and worsen the glycemic control. If we do the treatment, what we're doing is we're decreasing the inflammation. So that improves the insulin sensitivity, which results in improved glycemic control. The other risk factor is tobacco use. It's the strongest risk factor and predictor of future disease and treatment outcome. Why we say the outcome? Because they also compromise the healing. Severely immunocompromised in patients that they have these conditions, for example, HIV, and other risk factor is stress, which has a weak possible association. So it's important. What does it tell us here? It's important to get to know patients' medical history thoroughly. For every positive answer, we have to do the review of system, which is a bunch of probing questions and detailed about the condition. For example, if your patient tells you, I have diabetes, you need to know what type, when was it diagnosed, are they monitoring their blood glucose by themselves, which is self-monitoring, or are they doing it when they visit their physician only? What's the average number? What is the highest they get? If their doctor changed their prescription or the type of the medication or the dosage recently, which it sometimes indicates that the control was not satisfactory, the glycemic control. When they did do it, how frequently they did it. So these all are for us to know what's the patient compliance with this condition and how they control it. Sometimes patient can show up in your office, you measure the blood glucose, the level is very good, 6, 7, and you're happy with it, but it doesn't show the long-term compliance of your patient. For that, you have to look at what's the number for the HbA1c, which is the glycosylated hemoglobin formed continuously in the red blood cells, and gives an indication of the long term, almost 3 months of the diabetic control. The normal is usually between 6%, below 7%, but the binding of glucose to hemoglobin is very stable. Hemoglobin remains glycated for the life of the red blood cell, which is almost 3 months. So that's the one can tell you how well controlled the glycemic level, how well controlled is that your patient's condition. There are other bunch of, we don't call them risk factors, we call it risk indicators. They are the one that they come across and they concluded they have something to do with the periodontitis through the cross-sectional studies. Age, gender, socioeconomic status, education, access to dental care, race, ethnicity is some of it. Some of these risk factors and risk indicators are modifiable, like smoking, and some are not modifiable. We can't do anything about it. It's age. Or other ones, whatever you think that it's not in our control to make any changes. So from paying attention to risk factors and bringing into account all the risk factor evaluation into periodontitis for the diagnosis and treatment of periodontitis resulted in coming up with different risk assessment tools. So different risk assessment tools are developed, and such as this one, but like this one, we look at diabetes, immunosuppression, osteoporosis, tobacco use, socioeconomic status, access to dental care, dental IQ, compliance of the patient, level of oral hygiene, gingival inflammation, percentage of the sites with pocket depth more than or equal to 6 millimeter, clinical attachment loss, considering the age of the patient. Is it consistent with the age, or we're seeing a lot of clinical attachment loss in a young patient? So that's how, using these risk assessment tools, it gives us to focus on the evaluation of these risk factors. And American Academy of Periodontology statement indicates that periodontal risk assessment plays an important role in periodontal treatment planning and should be part of every comprehensive dental and periodontal evaluation. We cannot just treat our patient by looking into periodontal condition only. We have to consider the overall health, their lifestyle, the risk factors around them. So the current periodontal treatment is mainly based on a repair model of care. We identify there's a problem and the damage is already done. And our treatment is mostly focused on repairing the problem. Now that we know the host factors are very important, that's why the future model of periodontal treatment will be more based on the risk indicator and risk reduction and prevention, with a greater emphasis on the medical and wellness model of the patient care. So that's why it's very necessary to do a periodontal risk assessment. And if we need to consult with the relevant healthcare providers to find out about the overall health. The take-home message is, look at the bigger picture. Look at your patient's overall health, not just their oral health. So look at their medical history, social history. Look at the big picture. With that, I want to thank you for your attention, and I hope you enjoyed this presentation. Hope to see you soon. Have a great day.